Hello, everybody, and welcome back to Emergency Medicine Quest. In this part, which is part 2 of oral medicine, we are going to discuss lots of other topics. So make sure to like, share, and subscribe to the channel for more such content. For odontogenic and deep neck infections, let's first understand the classifications and categorizations. So, for odontogenic infections, we can divide the spaces into maxillary areas and mandibular areas. In maxillary, further, we can subdivide it into infections of maxillary canines can lead to a canine space infection, and they often present with a patient ipsilateral nasolabial fold flattening. And what we are worried about in canine infection is basically a cavernous sinus thrombosis. For the buccal space, so normally it is the buccinator area where maxillary molars get involved, but sometimes it can also be mandibular molars. For mandibular infections, so we have three primary spaces. There is submental, sublingual, and submandibular. The submental space is bound by the digastric muscles, and therefore the swelling that happens in a deep neck infection in this area is very discrete. Normally, the teeth that is implicated is mandibular incisors. The sublingual space is between the floor of the mouth and mylohyoid muscle. Since sublingual space does not have a posterior border, it can communicate with the submandibular. Normally, these patients are going to present with tongue elevation and firmness at the floor of the mouth. Finally, submandibular space. So this is basically an extension of infection from the mandibular molar. If there is an infection that encompasses submental, sublingual, and submandibular, it is known as Ludwig's angina. Ludwig angina is basically a bilateral board-like swelling involving the submandibular, submental, and sublingual space with elevation of tongue. And what we are most worried about in Ludwig's angina is our airway obstruction. The most common organism for Ludwig's angina is a hemolytic strep, but there can be a mixed staph strep flora, and sometimes there can also be bacteroids, which is an anaerobe. So remember recent dental work or trauma, some recent airway manipulation, IV drug use, sinusitis. These are all predisposing factors for deep neck infections. Normally, when these patients present with any swelling, tenderness, complaints of erythema, and fever and malaise can also be involved, then we need to do a very thorough head and neck examination. We can sometimes percuss teeth to assess for tenderness, which indicates a periapical abscess. What causes trismus in deep neck infections is basically involvement of internal pterygoid muscle or masseter. Patients will also present with a hot potato voice or difficulty swallowing or handle secretions, which basically implicates a partial airway obstruction because of a retropharyngeal or a parapharyngeal infection. Diagnostic wise, Many doctors they order CBCs and it may show leukocytosis, but remember that the absence of leukocytosis does not rule out a deep neck infection. When there is a concern of deep neck infection, the best imaging to do is to go for a CT. So CT is recommended if there's a deep space infection. How are we suspecting a deep space infection? If there is facial swelling, if there is restricted mouth opening, if there is a voice change, if floor of mouth is elevated and there is dyspnea or odynophagia. There should be a very low threshold in immunosuppressed patients, especially those with HIV and diabetes. Management wise, if there is a patient who is coming with an odontogenic infection, is well appearing, vitally stable, no recent antibiotics, and is immunocompetent, then we can just discharge these patients on antibiotics. If there is a simple tooth abscess, we can do a local drainage. But if there is a serious deep neck infection, then they need to be on broad spectrum IV antibiotics. So some of the IV antibiotics that is mentioned and recommended in Rosen's is IV ampicillin sulbactam with vancomycin. This is a regime for a normal immunocompetent person with no penicillin allergy. If they are allergic to penicillin, then we can move over to clindamycin. And if the patient is immunocompetent, then the better regimen would be to give meropenem and vancomycin. Remember that with Ludwig's angina, the concern that we had was airway compromise. So naturally, we are going to give antibiotics, but airway management will definitely be a priority. Remember, in these patients, if the airway is compromised, oral intubation is going to be difficult because the tongue will not be displaced with a laryngoscope. So in such cases, what is recommended is a video laryngoscope or a flexible intubating endoscope. Disposition wise, if there is a simple odontogenic infection, then we can discharge these patients for outpatient follow-up. If they're coming with severe odontogenic infections, deep neck infections, systemic toxicity, or they're immunocompromised, definitely these patients should be for hospitalization. If there is Ludwig angina with airway compromise, then these patients need to be admitted in ICU for further management. Dentoalveolar trauma is quite common presentation to ED and can involve any tooth. Normally, the one that is most commonly involved is the maxillary central incisors. Now, these teeth, they can either become concussed, that means if you touch their tooth, they are going to have pain on percussion. They can be subluxated, which basically means that the tooth is going to become mobile, but it is going to be in its anatomic position. It can become luxated, in which the tooth moves out from its anatomic location. It can become avulsed, in which the tooth is completely out of the socket, and they can have infraction, which is incomplete fracture of the enamel, or the tooth can get completely fractured. Now, when we discuss dentoalveolar trauma, we particularly discuss Ellis classification. So Ellis class 1 is basically a fracture of the enamel. It does not involve any deep layers. If you see a broken tooth and the tooth has got a yellowish tint on it, then this is Ellis class 2 because this is an enamel dentin fracture. And if you see that the tooth has a pinkish tinge or there is some blood coming out, then this is Ellis class 3 because now the pulp is also involved. Now, if a tooth is concussed, then the patient is going to come with tooth pain, but the tooth in itself will not be mobile. But subluxated or luxated injuries represent a more serious injuries. Even if the tooth is subluxated, that means it's mobile, but it is in its anatomic place, then it is going to heal as long as no further injuries occur. But we can further classify luxated tooth injuries into extrusive, intrusive, and then we've got a lateral. So extrusive is basically when the tooth is forced out of the socket, so it appears longer, and it is out in an axial direction. Intrusive is when the tooth is pushed inside or pushed in a apical manner. So here the tooth is going to appear shorter. We have a third category called lateral, in which basically the tooth is going to be side to side. When the patients come with dentoalveolar trauma, they are going to come with some sort of a history. So maybe a fall, a hit. Reimplantation of a pediatric tooth depends on whether the tooth is primary or secondary. If it is a primary tooth, then we don't reimplant it. So when you see such patients, inspect the tooth, evaluate for fractures, look for any tenderness, look for mobility, look for percussion, look for the oral mucosa and tongue, which can sometimes be involved, especially in severe cases of trauma. The diagnosis of dentoalveolar trauma is clinical, so no diagnostic test or imaging is required. Now, the management principle of these patients. So first thing what we do is manage their pain. Before we do any manipulation of the teeth, we have to give analgesia. Now this can be in form of supraperiosteal nerve block if the tooth is isolated, or if multiple lower teeth are involved, then inferior alveolar nerve block. As it is with any trauma, we check for patient's tetanus and we have to update it accordingly. Now, management specific to the kind of trauma. So if we come back here to the dental fractures, so for Ellis class 1, there is no emergent treatment needed. For Ellis class 2, calcium hydroxide paste can be applied to the tooth. For Ellis class 3 also we have to apply calcium hydroxide. Both these two classes require a 24-hour referral to the dentist. In cases where tooth gets avulsed, especially if it is permanent teeth, then it should be reimplanted at the earliest opportunity. Remember that in general, teeth are likely to be non-viable if they are dry over 60 minutes. In the pre-hospital setting or in the first aid, what can be done is, if the tooth has been avulsed, then it can be stored either in Hank's balanced salt solution, or something that we have in all our homes is milk. Saliva should only be used if no other medium is available, but do not use water to store teeth. And when we are dealing with permanent teeth, remember to handle them by the crown, because we don't want any injury to the periodontal ligament at the root. So as a rule of thumb, if the tooth is stored in milk, then it increases the viability to 3 to 8 hours. And if it is in Hank's solution, then the viability of the tooth is 12 to 24 hours. This brings us to the end of oral medicine chapter.